Thank you, everybody. I'm, are you able to hear me? Just me. So, thank you for the organizers for allowing me to talk about this. And thank you, Dr. Fuller, for a wonderful start of the conference. You just made my life much more easier because I'm going to reference to what you just said so many times. Uh, so, let's talk about assessing cancer treatment efficacy. I'm going to start off with, I had a disclosure slide, I have none. I'm going to start off with some provocative statement by our old Supreme Court justice. So this is in 1960s, and in case between obscenity case of Jacobellis versus Ohio, Supreme Court Justice Porter Stewart very famously said, "Hardcore pornography is hard to define, but I know it when I see it." And by that context, it's very similar when we talk about treatment efficacy and response. And around the same time, Charles Mortel in 1970s started trying to identify what do we call response. So what he did was very simple. He was a lymphoma doctor, so he had few of his colleagues, so 16 hematologists, and had 12 spheres of different sizes, and kind of wanted to see how well a physician can see the changes in the tumor or the spheres that he had. So 12 solid spheres from 1.5 to 14 centimeters, and then he layered it with a 0.5-inch thick kind of layer of foam to make it replicate your skin and subcutaneous tissue. And for abdominal, for larger tumors, he kind of had a larger foam. So, and then he threw in a curveball. He had tumors 5 and 6 and 7 and 8 to be exact same size. There might be some millimeter difference between the sizes based on the how the spheres were made, but the purpose was essentially to keep them the same. And what he did is he tested how either two different investigators or a single investigator can assess the difference between the spheres. So let's look at how did two investigators think that the same tumor was different. And when they were given a criteria of, hey, tell me whether there is 25% shrinkage, you can see around 25% they thought that there was some response when there was actually none. When you increase that limit to 50% shrinkage, and the shrinkage that defined was by perpendicular criteria and not just unidimensional, so they used bidimensional. They were allowed to use rulers, measuring tapes, or calipers, whatever they had at that point in that time. So at 50% shrinkage, yes, that variability significantly reduced to 7%. And he also tested how many times the same person thought which was the same tumors or same size were different. Same thing, when there was a criteria of a just 25% reduction, they thought, yeah, this looks different. But when you apply a larger reduction criteria of 50%, then yes, that error, as we say, it kind of reduced. And this is kind of summarizing the point that I just made. So this is our humble beginnings of how we assess response in cancer, basically. And they kind of concluded in their famous paper in 1976 that, hey, that if we use 25% criterion, we have a lot of error that we kind of introduce, and we say what something might not have changed, we kind of assess this as change. But when we kind of increase that, oh, hey, if there is a 50% reduction, I think they thought, yeah, that's probably where the bias or the error reduces. Now, this is very simple, humble start and if you think about it, this is more of an operational reason rather than a pure assessment need. But one of the important factor here is they were thinking about lymphoma. But some of what I will show you is now applied very widely to all solid tumors, including various histologies and various areas. So from here, WHO basically codified our definition of response and then RESIST in a way immortalized it. So just to show you the difference, WHO is what used 50% diameter and it's bidimensional decline, and that's what we called as response. And then RESIST, which is response evaluation criteria in solid tumors, came about, and they utilized at least 30% reduction, and it can be unidimensional. Now you say, okay, what's the alignment here between 50 and 30%? So just to talk about how unidimensional, bidimensional, and sphere kind of sizes align with each other. Basically, 30% decline in a unidimensional is basically a similar to 50% decline when you are measuring it bidimensional. But if you're measuring in sphere or volume, that kind of accords to 65% decline. So when we have newer techniques which are emerging, which are more volumetric, and they set their bar at 30%, I do kind of view them as like, really, that's what we want to set a bar. We are reducing our bar of what is calling response by basically half. In terms of disease progression, they both didn't align. RESIST uses 20%, so it allows for larger increase in the tumor size before we call somebody has progressed. So the gray area between response and progression, what we call a stable disease, has kind of is larger in by RESIST compared to WHO. So I'll tell you an interesting phenomenon here. So this is some colon cancer data that we had. So if you see on the top graph that, okay, those who had no reduction did the worst. Those who had 1 to 20% or 29%, less than 30% reduction did a little better. But those who had more than 30% reduction did the best. Great. What we thought in a very simplistic way works extremely well. But when you actually further stratify this data, and then you kind of separate out the first line treatment and the later line treatment, there is a major gap here. So if you see in the first line treatment, those who did less than 30% of response almost kind of in a way ended up being as if those had no response compared to those that more than 30% response. And if you look at later lines, any response was good. So this is very important when I think of response. So if I'm giving a patient any treatment first line, I want the best response I can get. I want the CR, I want the best PR, I want the maximum reduction that I can get because I know that will really change the outcome. But at the later lines, even if I can stop the disease from progressing, I'll take it. I'll take that as a win, and I kind of continue. So question comes, why do we need new methods? This works relatively okay. I think few things kind of matter here. One of the thing is there is a major difference in how we think about it early and late clinical development of any drug or any new method. The late overall survival, for example, is the gold standard. But if you want to do a new drug study of phase 1 or phase 2 and you put overall survival in prostate cancer, best of luck with that. It's probably going to take you more than a decade to kind of actually identify. So your early stage markers are always response rates or overall response based on progression or even PSA or anything even saying that, hey, this can work without much toxicity and not really necessarily change your outcome in terms of overall survival. So this is where some of the work I am doing I'll talk about. So one thing that we know is cancer usually grows exponentially. And that's the basis of our theory. So what you see in clinic when you give somebody treatment is the blue curve here. And this is the theory behind the model of tumor growth rate. And Dr. Fuller very nicely said there are two factors. There's this AI factors, and then there is this hypothesis-driven factors. And we are trying to basically combine them. So there is some hypothesis here that, okay, this blue line is how it works. So what is this blue line? Basically, what I am saying is that tumor is an heterogeneous mass and not a singular blob as we used to think about it. So what two things are happening simultaneously. One is there is growth of the therapy resistant fraction, and then there is regression of the therapy sensitive fraction. So what you might end up seeing is that you see this regression and you see this blue curve or PSA, for example, or in imaging any tumor size going down, and then it slowly curves around and starts growing. But the therapy resistant factor had been growing all the way. And that's the idea behind this model. What we are trying to predict that at any particular time, what might be the tumor growth or size of the tumor. It depends on either the regression of the therapy sensitive factor and the growth of the therapy resistant one. So without kind of going much into details, we've developed an R software. It's free to use, easily available. And the idea is that we should be able to obtain tumor growth rates even when patients are technically having reduction in size of the tumors. So what do you put in? So you put in some identifier. At what time point did you collect the data and the size? Size can be sum of all tumor measurements looking radiographics, or for prostate cancer, specifically, I utilize just PSA. You say, why did you do it? Because that's something that every clinician does when patient enters their clinic every single time when they're coming to see them. So that's something that it's utilized very widely, but hasn't always been a sole endpoint in clinical trial and hasn't always necessarily correlate with overall survival that well. So that was our first step, that, okay, if PSA doesn't work, then we need to look for something a little more detailed like imaging criteria. And this is what the model kind of gives you by itself. So the red dots that you see are the actual data points. So these are the PSA values that patient had. And then it tries to fit between four of the curves that we kind of divide into. And this is model doing it by itself. Okay. When I started this, I said that tumors grow exponentially. So there is a correlation of tumor growth rate into tumor doubling time. Basically, when you divide the natural log of 2 by the growth rate, it gives you tumor doubling time in days. And you say, why do you need to do this? If I were to say a G of 0.0024 per day, it means meaningless to a physician. But if I say, hey, your tumor doubling time is 280 days, oh yeah, that makes sense. And then that's just more utilizable. So you should ask, like, why even do this? First, we kind of looked at old clinical trial data. And looking at old clinical trial data of around 1,000 patients in prostate cancer, we noted that slower the tumor growth rate, better the survival. So the blue curve is the patients and the quartile which had the slowest tumor growth rate. Now, after looking at clinical trial data, we wanted to see, okay, fine. In a perfect world, this works well. How about in a real world setting when one would have to apply this day in, day out? That's why we turned to our VA systems. VA is one of the oldest medical record system with the largest data sets available if you know how to access and mine it. It's basically a national level data resource that you can tap into. Without going into complexity, basically all data gets into a corporate data warehouse that VA has, and then you have access to it through inside of their firewall. As of last year, we amassed a cohort of around 38,000 patients. And we, as you see, we have a lot of different details regarding patient treatment, whether that's their dosing, their PSA values, and some of their comorbidity and demographics and other lab data as well. Just to make a point, most patients had a monthly PSA assessment when they were at the VA, and you can see the variation. The large plots are basically at that particular time point. Now, here's a slide that tells everything by itself. On the left is some of the clinical trial data, and during our initial pilot, we added some VA data into it as well. So that's around good 15,000, 10,000 patients at that point. And we had so much so many patients, and we had a method which was pretty good at predicting overall survival. We had an octile and not just a quartile. And as you can see, all the curves separate very well, with the slowest tumor growth rate patients having the longest survival. And it's very linear rather than an abrupt that, oh, I have to use a cutoff of a particular percentage to kind of tell where and how a patient is doing. On the right, now we have even more VA data. So you're like, okay, let's make a decile. Same thing gets replicated again. Slower the tumor growth rate, better the survival. Now, important factor. These patients got multiple different treatments. They got either hormonal therapies. These are most metastatic prostate cancer patients. They got hormonal therapy, chemotherapy, targeted therapy like PARP inhibitors, and they were all jumbled in sequence as well. So somebody's getting some treatment as first line, somebody's getting some treatment at a later time. So most of these patients got some treatment before or some treatment after, or even two treatments after. But what interesting part is, just looking at their PSA-based tumor growth rate when they are getting this particular treatment at that particular time point in their life, we could still predict overall survival for this patient so accurately. And this is just for the statisticians in the room, that it has great correlation with a Cox-based estimation hazard ratio as well. And if you know, R square of 0.99 is something that you rarely end up seeing. Now you say, does it really work for all medications? So yes, so we looked at specifically for hormonal treatment for prostate cancer, same results. Chemotherapy for prostate cancer, two different ones, very same results. And targeted therapy like PARP inhibitors that we use for BRCA mutations and some other hormonal recombination repair defect patients. Now, one interesting factor that I would also want to put is, we can actually predict response even if patient's PSA is not declining. So this is a great example of that. These are around 11,000 patients who got a hormonal treatment for metastatic prostate cancer called abiraterone. If you see, around 4,000 of them never had a PSA decline. That means their first PSA when they started on treatment was the smallest, and they always had higher PSA afterwards. But if you see the next line, we stratified this chart by looking at their growth rate when they were getting their treatment, and that's basically the highest growth rate to the lowest on the right. And if you look at the bottom line, you can see even for those 4,000 patients who didn't have any PSA decline, we could correlate this with their overall survival. So this comes in very important and very helpful when you are giving a patient to a very later line of treatment, and you are not sure, should I continue this treatment? Should I just not? Should I switch to a different treatment? I don't know if this patient is responding or not. Seems to be clinically doing fine, but the PSA just keeps going up. And this is where it kind of can really be helpful as well. In terms of, we also, as I talk about, develop this G-rate based doubling time. I'll give a little idea behind it. So and how we've kind of utilized it. If you've noticed, when you give somebody as their first line of treatment, that usually works the longest. Then you give second line, it works a little bit shorter. Then you give third line, even shorter, and so and so. And that's the idea Daniel von Hoff used, and said that, hey, you know what? We can actually do something what's called as PF, progression-free survival ratio, and say, hey, if you are not progressing more than 30% compared to your last treatment, we'll call you a responder. So running with this, what we did is we utilized a G-rate based doubling time and said that, hey, if your doubling time or G-rate based doubling time on this treatment is better or same as the last treatment, we'll hypothesize that, hey, you kind of should be called a responder to this treatment. And you said, fine, okay, but how does that fare in terms of survival? We looked at specifically for patients who receive olaparib in the context of metastatic castrate-resistant prostate cancer, and had homologous repair recombination defects in their tumors. And we identified a smaller cohort as a pilot study for this of around 139 patients. So we said that, hey, if your ratio, that is, or simply put, if your doubling time on olaparib is the same or better than the last treatment, we'll coin as benefit. And as you can see, it kind of the treatment from the right side of the curve kind of you didn't have one particular mutation. Clearly, you see a lot of BRCA2, which are the red ones, but didn't mean that none of the would be coined as responders. And we could see a difference of 1 year in overall survival by coining this as one of an endpoint. And this is, as we speak, it has been accepted at eBiomedicine and will be published very soon. So this is one of the utilization of this method. And one of the last things that I would want to talk about is G-rate-based machine learning model that we are developing. And this is where we are trying to mix the world of hypothesis testing and machine learning. Now, you say, hey, your hypothesis and your statistical model works well enough. Why do you need to do anything extra to it? Well, what we are looking at is how well a patient is doing when they are getting a treatment. But getting a treatment has a lot of variables, correct? One is how well they are tolerating this treatment. Second is what treatment are they given that usually get decided on what other things they have. Do they have cardiac disease? Do they have other kidney issues? And that kind of gets played into factoring making treatment decisions for patients. So this is where our machine learning model comes in. The idea is that we use this doubling time and add other variables, including other medications patients might be getting at the same time when they are on this treatment, and predict patients' response based on it. We did some preliminary modeling already, and the model is performing quite decently, I would say, with an AUC of 0.72 with decent accuracy as of now. And with that, that's my last slide, and some take-home points that, hey, we are good at predicting response, but we can do better. And one of the ways I'm doing it is by developing this tumor growth rate method. Thank you. Yeah.
Questions? All right, and our next presenter is going to be Linda.
Okay, fantastic. So I'm going to be presenting today on artificial intelligence in prostate cancer risk stratification. This is largely an adaptation of my work with Dr. Bain and Dr. Lin for my PhD. But I kind of want to frame this presentation with the objective of not necessarily just highlighting one study, but giving you all kind of a framework with which to interpret other studies in prostate cancer and radiomics. Or it doesn't want to work. I have no conflicts of interest to disclose. And so I'll start off contextualizing this within prostate cancer. As we know, prostate cancer is the most common cancer among men with natural life history ranging from 10 to 15 years. Given this long natural life history, treatment and treatment efforts are not necessarily oriented towards oncologic effectiveness, but more so this balancing act between diagnosis and treatment of prostate cancer versus managing the side effects of such treatment. And so this is really a question of risk stratification. So this is the clinical care pathway for prostate cancer, as we know, ranging from things like PSA test and DRE for diagnosis and screening to biopsy imaging for grade and stage. This cancer pathway already gives us, by design, some ideas for risk stratification. And with that, several groups have already developed kind of clinical nomograms with the intention to predict recurrences early to allow for more proactive disease-tailored treatment. So the two nomograms up here that I'll highlight are the CAPRA score in the orange box there out of UCSF, and then the MSKCC nomogram, pre-radical prostatectomy, Memorial Sloan Kettering. And as our keynote highlighted, The problem with nomograms, whether AI or not, is really external validation. When developed in their cohorts, AUCs range pretty high from 0.8 to 0.9, but in external testing, actually inclusive of our populations here at UNMC, our AUC actually ranges for these nomograms 0.6, with some populations going up to 0.8. And so by the title of my talk, I guess we're going to talk a little bit more about imaging and how that can help reason this gap in risk stratification and prostate cancer treatment. Rather than relying necessarily on the macro characteristics, can we zoom in even further, look at things like tumor heterogeneity, tumor microenvironment to predict things like prostate cancer recurrence? And so this is where radiomics comes in. Radiomics, at a basic level, is a machine learning technology that uses massive data characterization techniques to extract subvisual or micro features from medical imaging. Think of it as zooming in on any given medical image into the specific pixels and the exact shade of gray that each one of those pixels can be, comparing those shades of gray into the pixels next to them. And from that comparison, things like shape, texture, contrast, brightness can start to quite literally take shape. And from there, can we aggregate those things into creating nomograms and models predictive of high-risk cancer, high-risk pathology, adverse characteristics, recurrences even. And so as with any good research project, so begins the literature review. We're looking specifically at MRI-derived radiomics for our study. The majority back in 2022, looking at the systematic review, the majority of articles published on MRI imaging and prostate cancer and the use of AI and radiomics, of the 33, majority actually concentrated on looking at adverse pathology or Gleason grade. So 15 and 11, those groups, versus endpoints such as surgical recurrence or post-radiation failure, with the minority of studies in these 4 and 3. While I'm not going to discount the kind of top 2 study endpoints, as I still believe that they're important in high-risk assessment, I kind of want to highlight the context of like recurrence and failure, since those endpoints give us kind of an actionable way to approach treatment, add on potentially adjuvant, neoadjuvant methodologies to improve recurrence outcomes. And for my project, I'm going to talk a little bit more about post-surgical recurrence rather than post-radiation failure. But zooming on in those 4 studies, this is a little bit more of a detailed view. Really, the only thing that I want you to gather from this slide, though, is that the methodology is really, really heterogeneous between these 4 studies. And the number of, can I see my mouse? Like even in images used, feature selection, region of interest, the number of features extracted, how they validated, et cetera. Really, the only one thing that most of them agreed on was to compare against those clinical nomograms. And actually only one of these studies, Lee in 2021 of 198 patients, included an external test set. And as our keynote pointed out, the importance of that validation is, utmost. And even in that study, rather than providing us with an AUC, where's my mouse? This study actually just gave us a hazards ratio and said that this radiomic model was significantly correlated, just a p-value, with recurrence. And so all of that is to say, and summed up in this slide, is that even though so far we've talked about radiomics and kind of AI as this kind of linear pathway, it's important to note that it's actually highly variable and unstandardized. Each one of these little boxes with like the dashed lines can actually represent a point in which your methodology can be shifted and modified. And as you can tell from the list, all of these different ways kind of create this infinitesimal number of combinations and probabilities. Are your images standardized? How are you extracting features? How many features are you extracting? And then whether or not your model is actually validated externally. And so as I transition more into our project, I'm going to talk about the intentional modifications to our radiomic pipeline that made our study a little bit more clinically reproducible. And when we did this within the context of clinical utility, the thought process was to eventually transition into clinical use. So the first thing that we did during the image processing and sectioning part of our project, we actually elected to use manual contour of the prostate rather than AI automated segmenting, kind of for two reasons. The first reason was because AI, as we know, is not perfect. AI is also subject to its own validation and often makes more systematic errors. And so rather than training a model to function at a baseline of systematic error, we wanted to include the human component. Therefore, later allowing for kind of clinical reproducibility and integration into our clinical workspaces. And so manual contouring it was. And then the second intentional modification in image processing was image normalization. I'll zoom in on this a little bit more. If any of you have ever edited in Instagram or in Photoshop or even on your iPhone, you kind of know that every image has a set like brightness, contrast, structure. You could change all of those things when you're photo editing. But what you can also imagine is that it's pretty difficult to compare two different images with like wildly different brightnesses. Can you actually talk about like a defined edge, defined contrast, things like that? And so the same thing happens when you're working with AI. This top part, you don't have to look too much at the axes, but these are the image histograms for actually 339 patients here at UNMC that we sectioned for our project. Image histograms are wildly variable in that top part. After applying this histogram matching technique, we kind of forced all the images to have the same levels of things like brightness, contrast. And that's when you're really able to start talking about, does contrast represent perhaps a Pyret's lesion, or does brightness represent like cancer infiltration, et cetera. And so with that, those were our two like image processing modifications. And then the last modification that I'll talk on, perhaps not a modification and more of a methodology thing, but was model validation. We designed our study to probably include too many different centers and different imaging protocols, but it was, again, done with the undertone and the goal of clinical utility and reproducibility. And so this slide summarizes kind of my experience with AI within the context of this project. I started on all of this in 2020 when I matriculated into medical school here, but our first model was actually not until August of 2022. And really, this was a preliminary analysis of just 76 patients here at UNMC, just to make sure our code worked, our imaging. Oh, we're getting an echo now. Okay, I'm gonna try again. Great. Just to make sure that our code worked, our histogram matching worked, we could feed images, do all of the things. That was just 76 patients. And then the numbers there in parentheses are how many surgeons, centers, and imaging protocols. So 2 surgeons, 1 center, 1 imaging protocol. The training here, the AUC was really great, as we would expect, since they're all pretty standardized, 0.95 in training and 0.67 in testing, which ultimately yielded 100% specificity and 33% sensitivity. But of course, this lacked external validation, which brought us to our second model here in June 2023, where we were perhaps a little very, very determined and very optimistic. We added 65 additional patients from 1 center who drew from 1 surgeon, 2 different centers, and 4 different imaging protocols. And then we also added, like I said, a little optimistically, 110 patients from 1 surgeon. But his practice was unique in that he only took patients by referral basis. He was largely a cash practice. And so we actually had 50 different centers of, at least 50 different centers of imaging, 50 centers of different imaging protocols from the United States, from Singapore, from Australia, all of the things. This is when I thought I would stop doing my PhD because there's so much heterogeneity. But on one fateful day in June 2023, we were able to use AI and develop that training data set into 0.89 AUC and then 0.78 in testing, sensitivity and specificity there. And then to the shock of my committee, I tried again and imposter syndrome, et cetera, but we added some more patients from that cohort just to prove that we could do it again for external validation, and ended up with this final model of 0.82 cross-validation, 0.72 testing, both of which were significantly improved from the nomograms from earlier. And so with the remaining time, I'll just delve a little bit more into this to give you all a framework of what this looked like. So this is our final cohort of 339 patients. They are representative of prostate cancer patients in age, stage, pre-op PSA. Follow-up time was 3.4 years, and then recurrence hovered right around 17% at that follow-up period. And then these are the image histograms, which took a lot of tinkering with. We actually removed that green line friend there because we weren't able to get the image histograms to quite line up there. But the rest of them were pretty standardizable, even despite the up to 100 different imaging protocols. And then from there, we were able to extract 18 radiomic features that were both non-redundant, but also highly correlated with biochemical recurrence. This is kind of a raw-ish output, and so some of these might not mean very much to you all. They don't mean very much to me either. I have to Google very often. There's 924 radiomic features, but most of them are materials conditions, like conditions of contrast or statistical features correlating with brightness, et cetera. Two on here that I will highlight are sphericity and flatness. Sphericity is just how round your prostate is, and you can imagine how a measure of not being spherical could suggest cancer invasion outside of the prostatic capsule, or flatness, which is really a measure of contrast and how that could correlate with something like a PIRADS lesion. So once all these 18 features were aggregated into our nomogram, these are our AUC curves, both in cross-validation and in test. And then the UCSF CAPRA scores and the MSKCC nomogram AUCs are there for comparison. P-values are not included, but are statistically different for CAPRA and MSKCC in cross-validation, and then in test, it is significantly improved from CAPRA score, but hasn't quite reached power to be significant in MSKCC. And so what do all these features mean? We're still working on it, but this is our correlation matrix between some of the radiomic features and the clinical features. So we're comparing like mathematical features versus Gleason score versus, let's see, these are slightly off. Gleason score, pretreatment PSA, and what is discussed in our paper is that some of these actually make a lot of sense. Like PSA density corresponds with kind of correlation of hot spots in the prostate, measures of contrast, like I said, corresponding with Gleason score, et cetera. And so as I wrap up here, I kind of want to give you guys all, again, a framework with which to interpret these results, but also interpret upcoming studies in radiomics, AI, and prostate cancer. And so in our specific study, our increased sample size not only yielded higher power and higher number of features, as well as the number of patients reaching our endpoint, but we also introduced, I think, heterogeneity in the right places. With all of this heterogeneity and imaging protocols, centers, et cetera, this model being able to already be generalized and created within 50 plus, 100 plus imaging protocols speaks highly to the generalizability to external centers and later possibly clinical integration. And with this improved methodology, we have models for increased image normalization and improved feature stability testing as well. And so on the horizon, as we look for future studies, we're not just looking at radiomic studies. We're looking at the combination actually of these clinical pathologic features with radiomic nomograms for prostate cancer risk stratification. And as AI continues to develop even more, how does AI interact with pathology, histology to create like pathomic, radiomic, histiomic, I'm just adding ick onto all of those specialties, but really to identify tumor heterogeneity in microenvironment with the intent of developing cross-disciplinary, perhaps tissue level targets to enhance treatment response. And with that, I leave you all with this quote and open it up to questions.
Excellent. Thank you, Linda. So we're gonna now just open up to questions for both Hartraj and Linda. So we'll take just the first couple here from the Q&A online, and then we'll open it up to the audience. But for you, Hartraj, what are the main limitations for this kind of growth rate methodology, and where are places where you could see this being potentially less effective, either in the GU space or even outside the GU space?
So I think one of the major limitation comes from is if somebody just had 1 or 2 time points, then it becomes tougher to discriminate. And if those time points are not too different, if they have less than 20% of difference between the 2 time points, then yes, it becomes less effective. And another limitation is, or I don't know about effectiveness. I would say one effectiveness or something that we've not tested is just surveillance. We've not looked into looking at patients who were being not treated initially and then what happens when they treat it. Rather, we are just looking at once you start the treatment, what's happening. So we are not looking in terms of declining growth rate immediately as you start treatment. And one of the reasons for that is that's not always readily available for physicians. You don't know when a patient presents to you, you don't always have prior data all the time. So that was a little bit pretty much pre-known that we do not want to venture into the space because then it will create a model which might give you some answer but might not be applicable realistically in the real world.
Excellent. And then you touched on it a little bit in your in your presentation, but kind of what's the relationship between growth rate modeling and overall survival, progression-free survival in cancer patients, actually choosing new drugs, things like that?
Excellent. So basically, if one takeaway I want you to take from my presentation is G-rate correlates extremely well with overall survival. And it provides better information rather than have a numerical cutoff of 30%, 20% or something. Lower you can get, better it is. And now with having a data of around 40,000 patients given this in real world, we have a web-based a model, not a model, but like a website slowly coming up where you can actually put your patients, you don't have to put any patient information, but you can put your PSA value, for example, and it will tell you what's the growth rate of the patient. And it will also tell you that based on the data we have of 40, 50,000 patients, where your patient stands, whether they are at one of those good responders or where they're maybe like not doing so well and you might have to be thinking of switching treatment. In terms of progression-free survival, in prostate cancer, if one thing we have done not that well is define progression-free survival. We've used PSA many of the times as early time point, but hasn't really worked. We've used kind of various imaging techniques, but prostate cancer gets defined into 2 different spaces. One is patients, those who have visceral disease, so those who have solid masses, versus there's a larger category of those who have bone-only metastasis. And defining decline in volume, right now, if you don't know, we define response in those is by looking at bone scans. You need to have 2 lesions, and then you have to repeat a bone scan again, and you have to have another 2 lesions for you to call progression. So, and right now, while PSMA PET scan is on the horizon, I don't think so there is a clear indication of how to utilize PSMA PET scan by itself as to assess progression-free survival in prostate cancer. So while we've tried to look at it in prostate cancer, but we've given there is so much variation between the two ways we define progression-free survival, we've not been able to kind of look at it in a good manner. But in other cancers, for example, lung cancer, this correlates with progression-free survival. And actually, sometimes patients were marked progressed if you just look by the actual progression-free survival criteria, but actually have survival improvement if you kind of look at by this method. And then that basically kind of tells you the idea that I showed, that you, as long as you have some response in later lines, your patient is still gonna be able to benefit from treatment as long as they are not having toxicity from it.
The next question is for Linda. So kind of looking at, all the work that you did, trying to move this again towards a clinical scenario, how can radiomics actually kind of be looked at for monitoring response, progression, et cetera, actually in clinic? How do we actually make this something that's real world applicable?
So that highlights a lot of the limitations of my current work. What I didn't show you in my presentation was a very fun slide of how many times we had to download an image, upload an image, download it again, and re-upload it again. And so as we are becoming more sophisticated in our, for example, AI segmentation or AI platforms, to be able to do those things without kind of a person behind the keyboard, behind the screen, eventually you would, the hope is to be able to get it to like a web-based platform, to be able to upload images and kind of get real-time correlation with areas that are of concern or monitoring progression, disease response, et cetera. But as currently is, we're not there yet.
Dr. Fuller? Yeah, so just a quick question for Dr. Fuller as well. Kind of what's the side effect prognostication model, or do you think the side effect prognostication models will ever be actually applicable in kind of a pre-planning setting to help kind of determine individualized patient tolerances and dose tolerances that can then be kind of put into the TPS?
Yeah, I mean, so interestingly, I think where we're going is exactly what you just heard from the last set of speakers, is we're exceptionally interested in serial growth models. We work with a guy named Heiko Inderling, and just like the G-rate work that was shown, that same phenomenon holds true for cytotoxic radiation or chemotherapy in many applications. And if you can create those curves for every organ site, well, the idea is if you say, here's how fast my tumor is growing, we can change the radiation fractionation or dosage to optimize the radiation planning. And in a very similar sense to what you saw with the radiomics presentation, if you say, hey, I have some indicator of the non-volume related, non-kinetic risk factors. If you say, here's a high-risk patient and I cannot miss and I cannot avoid organ at risk, that's a pre-planning constraint that you can have as these prediction models develop. But the key is you've got to have these strong priors about the outcome of the cancer before you get too cute on the side effect profiling. So I think it's very important to understand that as we get rich data on outcome information from radiomics and growth models, that allows us to then flex those. If you can trade, Takis Mavroidis has some really nice work that says, if you can trade 3% in your tissue control probability, you can get huge gains in your organ sparing. But if you can't trade that 3% because you've got a fast growing or radiomics indicated high risk tumor, and then you take the toxicity hit and keep the patient alive, right? So I think at the end of the day, this integrated model that you're seeing described is the way to go for all of these processes. I have a quick question. So with the radiomics, you described, you had this incredibly diverse radiomics, data set from the outside collaborator. Do you see that within that data set that there were specific facilities that had, highly indicative or usable images, or were there some that were just really bad quality? Was that a function of CT artifact? Like, what was in your mind? What was that? Was that heterogeneity something informative that you saw that you could use later?
Yeah. And actually, I think we were pretty lucky because we're doing this retrospectively, right? And so all the images that were included in this were things that have already been used for clinical practice. And so I think that flushed out a lot of like the crazy images that would have been redone otherwise, other than that one green line on the image histogram, which we couldn't, like, it was honestly just really bright and we couldn't assess any contrast or anything from. So I think that that bias is important to note. I didn't appreciate any of the kind of erroneous images, and so I can't really comment.
In interest of time, we'll just do one last question also for Linda. But I mean, how did we end up handling variability in image quality and the different protocols when kind of applying 3D across the different machines?
Yeah, and I think the biggest thing was that histogram matching, which is not so far in the 4 studies that I highlighted in our literature review. That type of like image standardization has not been widely applied. And so if we had tried, and we did try to do it without the histogram matching, it wouldn't have worked. And so I'm happy to discuss that methodology with anybody if you're interested. But that was, I think, the main crux of the project, and being able to kind of achieve comparability between institutions and protocols.
Excellent. Well, thank you both again. And